Well, hello everyone out there, and welcome to our webinar, From Field to Floor, Maximizing CPR Efforts and Perfusion with Progressive Protocols, including ECMO. My name is Janet Poe, the host for today's webinar, and our presenter today is Julianne Eigner. Ms. Eigner is the Acute Mechanical Circulatory Support and ECMO Program Coordinator at Scripps Memorial Hospital in San Diego, California. She specializes in advanced mechanical support in cardiogenic shock, respiratory failure, and resuscitation, and has over 10 years of experience in clinical and leadership roles in the cardiac ICU. Julianne has spent the last few years developing and implementing resuscitation and mechanical circulatory support protocols in an effort to optimize survival and improve patient outcomes. And she is going to share with us today some of those new ideas, technologies, and progressive protocols that have helped cutting-edge hospitals achieve higher quality CPR, significantly increase cardiac arrest outcomes, and simultaneously enhance their best practices for future hospital initiatives. We should have time to address questions after the presentation, so feel free while listening to enter your questions in the questions section of the control panel, and I will forward those questions to Julianne for her to answer at the end of the presentation. And so that we keep to the 1 hour time allotment, I will provide any extra questions to Julianne for her to answer via email. And also there will actually be a couple of scenarios presented during the talk where you will have the opportunity to participate by answering a couple of simple poll questions. And with that, I will now turn over the presentation to Ms. Julianne.
Well, thank you for the kind introduction. I'm going to share with you really our Scripps journey toward a successful resuscitation program that includes ECMO for very select patients. Just a couple of my disclosures here. I am going to be talking about ECMO for off-label applications, and I am a consultant for Zoll. So cardiac arrest remains really a leading cause of death in the United States with very little change in survival over the last decades actually. And despite the poor outcomes associated with in and out of hospital cardiac arrest, there's very little investment in improving outcomes compared with other disease states. So why is an ECMO and mechanical circulatory support coordinator talking to you today about cardiac arrest and talking to you about resuscitation? Well, let's be honest, the resuscitation quality is really instrumental to the success of any ECMO program and their outcomes. So let's quickly review the physiology of CPR in the two phases. The first phase is the compression phase. This is the cardiac output cycle, right? We're pushing down on the heart, creating positive pressure in the chest, emptying the heart, blood is expelled. During this phase, air rushes into the lungs and intracranial pressure rises. The second phase of CPR is the decompression phase, or also known as chest wall recoil, right? This is the preload where we're allowing the chest to relax. We're allowing the heart to refill with blood. But what that's creating is a negative pressure vacuum within the thorax. Air rushes into, exits the lungs, and then we see the ICP drop. So CPR circulates blood by the creation of these alternating positive and negative pressures inside the chest. The graph here, if you look, you see a positive pressure ventilation, and then you see CPR along the tracing there. The chest compression phase, again, is that positive pressure producing cardiac output. But what you see there at about -4 millimeters of mercury is that negative pressure that's created in the chest when we have chest wall recoil. And that's really critical because it allows the heart to refill and create that preload for the next compression phase. So we know that even under the best circumstances, CPR offers limited blood flow. According to the American Heart Association, 10 to 30% of normal blood flow to the heart and 30 to 40% of normal blood flow to the brain. So even under the best conditions during CPR, cardiac output is limited. So why? Why is cardiac output so limited during CPR? Well, we think it's twofold. The diminished intrathoracic vacuum that we talked about is going to limit preload. And if your preload is limited, then you don't have any forward flow for your compression cycle. And then, of course, poor CPR quality, improper rate, depth, incomplete chest wall recoil, frequent pauses, hyperventilation. We all know during an arrest how many times we stop and pause on the chest for whatever intervention we might be doing or whatever confusion might be going on because codes are chaotic. According to the Resuscitation Outcomes Consortium, they looked at 3,500 patients who were undergoing CPR by trained EMS personnel. So these are professional providers who have been trained to provide BLS And what they found was that less than half, so only 45%, were actually receiving acceptable quality of CPR. And that was defined as a rate of 80 to 100 compressions per minute, a depth of 4 to 6 centimeters, and a CPR fraction of greater than 50%. And what a CPR fraction is the amount of time, or the percentage of time, that somebody was on the chest when the patient actually needed chest compressions. So that importance of the chest wall recoil is really critical. Preload is absolutely dependent upon chest wall recoil. And we know that respiratory fatigue, stiff, non-compliant chest, broken ribs, which always occur during chest compressions, and compressions that are just too fast result in the inability for the chest to actually recoil and produce better preload. This is an actual tracing of an EMS provider where that vacuum failed to develop because of incomplete chest wall recoil. So you see the positive pressure ventilation. And then again, you see the zero line for negative pressure, and we never achieve negative pressure at all in that chest. So really, the take home is that high quality CPR is essential. And what that looks like today, and I'm sure it will change next year when the new recommendations come out, is a depth of 2 to 2.5 inches, a rate of 120 per minute, allowing for full chest wall recoil after each compression, a CPR fraction, or being on the chest when the patient needs compressions greater than 80% of the time, and a ventilation ratio of 30 to 2. So why is high quality CPR not enough? What else do we need to do to improve these outcomes? Because again, these patients still remain the highest mortality rates that we see in and out of hospital. So it's not just that high quality CPR, it's really the spectrum of resuscitation and how all of our different units are married. So it's the pre-hospital setting, the EMS providers training and education, your lay people, your bystanders, the emergency department's receival of the patient, the arrival in the care, and then the post-arrest care in the ICU. All of it has to be a continuum. So we know that cardiac arrest survival, again, is this continuum of care. And what are we doing on the hospital side to improve these outcomes? We know that there are really progressive places, Alameda County, Rialto, Minnesota, the Twin Cities, where there's very progressive protocols in place for out-of-hospital cardiac arrest patients. There's training that goes on in 5th grade, 8th grade, 12th grade for bystanders to learn the basics of CPR. But what are we doing in the hospitals to improve our outcomes? And that's really where the Scripps story comes into play. So the CHEER trial back in Melbourne, Australia, this is out of the Alfred Institute. Early in 2011, they took a look at only 26 patients who were in and out of hospital cardiac arrest, but they were refractory to conventional CPR, meaning they'd been defibrillated multiple times, they'd received multiple rounds of epinephrine and other medications, and yet the patients continued to stay in VFib or VT. Again, only an N of 26 patients, but what they found when they took a bundle and applied it to every single patient was a pretty profound survival rate with neurologically intact patients. So what their bundle looked like was mechanical CPR with an auto pulse device. They did ECMO and or PCI or percutaneous coronary intervention in the cath lab with every patient, and then they cooled every single patient. Again, 26 patients, but what they found was 54% or 14 out of 26 patients went home with CPC-1 scores, meaning they were neurologically intact. So that really changed the way we thought about resuscitation and applying bundles that included mechanical support or ECMO to these patients in refractory cardiac arrest. So much so that in 2015, the American Heart actually recommended that eCPR or extracorporeal cardiopulmonary resuscitation be considered among select cardiac patients who were not responding to initial conventional CPR. It does go on to say that it has to be in settings where it can be rapidly implemented. It talks about needing a multidisciplinary team, that it's a very complex process, that you need specialized equipment, specialized programs, and that there's not a lot of data really that's out there, and there's not a lot of literature that supports this. But as we've seen in the last couple of years, there's more and more studies coming out about this. So what is ECMO? For those of you who aren't doing ECMO in your institution, it's quite simple, really, the physiology. It's extracorporeal or out-of-the-body way of providing cardiac and lung support to patients whose lungs or both are unable to provide adequate oxygenation and ventilation to sustain life. So oxygen-poor blood is drained from a vein. It's circulated outside of the body on a mechanical pump. It crosses an oxygenator where CO2 is diffused out, oxygen is hypersaturated in hemoglobin, and it's reinfused into the patient. So when we apply that to CPR, it's referred to as extracorporeal cardiopulmonary resuscitation, or eCPR, and it's really the rapid deployment of ECMO to provide immediate cardiac support for patients who have cardiac arrest that is unresponsive. And that's really the key thing here, is we're not talking about every single cardiac arrest patient. We're talking about the refractory cardiac arrest patients who we can shock, but we really have no response. It's capable of circulating 5+ liters of blood per minute, depending on the cannula size and depending on the pump. But the reason it's so cool is that it stabilizes patients until further diagnosis can be determined. So we can support a patient on ECMO rather than hemming and hawing over what do we think is causing the arrest. We can support them on ECMO and then figure out what's going on. And patients can actually remain in VFib or VT while they're on ECMO, while the providers can figure out what's going on. We know that some of the data coming out of the Minnesota Resuscitation Consortium is that these patients who are refractory to defibrillation, refractory to epinephrine, refractory to conventional CPR, are staying in these rhythms not because something going on with some other comorbidity. It's actually because they have really profound coronary artery disease and they need to get to the cath lab for percutaneous coronary intervention. So the use of ECMO in that setting is quite profound in the sense that we can support these patients and we can provide oxygenated blood to their organs and brain, right, which is the most important organ, and we can support them until we get them to the cath lab to get PCI. So again, why is an ECMO coordinator talking to you about this high quality CPR? Because if we have a dead brain because the resuscitation was poor prior to ECMO, then it's all medically ineffective care. We see multi-organ failure with bad resuscitations. We see ultimately neurologic death. So who can be considered for eCPR? And really this is something that can be done pre-hospital. We believe that at Scripps, our criteria are that it should be a witnessed arrest on a shockable rhythm. Again, those shockable rhythms are important because the data to support survivability from an asystole arrest is quite poor. So we know that a shockable rhythm is most likely in refractory arrest because of coronary artery disease. We're an adult center, so we do age 14 to 70, and we say a loose 70 because, again, it's hard to determine somebody's age when they're arresting in front of you. CPR initiated immediately following arrest. So we want that to either be a bystander or a medic, or, we're in Southern California, so if it's at the ocean, we want it to be a lifeguard, and collapse with time to ECMO flow less than 60 minutes. So that is on-scene time of the arrest, and by the time they're transported to the hospital, and by the time they can be cannulated and placed on ECMO, we want it less than 60 minutes because we know the data supports better survivability. These criteria can really be educated to and determined pre-hospital by EMS providers. And these patients should be routed to a resuscitation center. And what that means is, we have stroke centers, STEMI centers, trauma centers, but we don't have resuscitation centers. And I find that ironic considering the amount of patients who die every year from it. And so we would describe that as an emergency department or a hospital with immediate cath lab and ECMO capabilities. Again, the cath lab is so critical because of the coronary disease, and the ECMO capabilities because we want to be able to support those patients until we can get PCI completed. So this is what it used to look like at Scripps. I'm not going to lie, I love our hospital, but we were a little bit disheveled about 5 years ago when it came to resuscitative ECMO. We knew that we needed to try ECMO, but we would have newer nurses and staff say, echo? What do you mean echo? Oh, ECMO, what is that? Nobody really quite knew. And we didn't have a very streamlined process for emergently cannulating and getting a patient supported on ECMO. We would call the code nurse. They weren't educated. We would bring the cart. Nobody knew how to use it. We would call in perfusion. They would take 30 minutes for them to get there. So we took a hard stop and we said, okay, hold on. If we're going to have this program, we've got to do it right. We can't have our nurses and our ancillary staff suffering because we don't have a process here. So we took a step back and we looked at what does our bundle of resuscitation need to look like. So what does it need to look like when we have a patient who is in refractory arrest? And then we thought, could we apply it to every single cardiac arrest patient? With or without ECMO, should we have the same bundle of care? So for us, we thought that looked like having automated CPR. So truly, automated CPR can calm the room. It frees up an extra individual. you know that your patient's receiving high quality CPR at the right rate, the right depth, and the right CPR fraction, because we can keep CPR going when the patient needs it the most. We knew that we were going to continue excellent ACLS and utilize feedback. We use monitors that give us feedback on our CPR. It'll tell you to push harder, it'll tell you to push deeper, it'll tell you to push faster, and it allows us to review the codes after the fact. We knew that we needed PIT crew roles and an ECMO team. That was going to be a separate team. And we even went so far as to change the choreography of how we received patients into our emergency department. Historically, we had our medic gurneys rolling into the left side of the patient's bed in the resus room. And we switched that because all of our providers were right-handed. So our physicians are focused not on running ACLS, but they're focused on procedures. So if the patient has not been intubated in the field, our physicians will get sterile, start at the head of the bed, intubate the patient, and walk directly to the groin to achieve groin access in the femoral artery and the femoral vein. And we do that with every single resus, every single time, no matter whether or not we use ECMO. We looked at placements of our line carts. We looked at placement of an ECMO cart. We use mechanical CPR, like I said, and we use our ED techs to manage those. And our nurses, again, they have very specific roles every time, and it never changes. And so what these roles look like is our primary doc, again, like I said, is focused on procedures, not ACLS. So there's airway access and groin access. And what's really empowering from a nursing perspective is that our primary nurses are the team leaders. They run the ACLS. They scribe the code, and so they're always looking at time. And they're really the leader in the room leading the orchestra, essentially, to the choreography of the resuscitation. We have the capability now of rapid ECMO team deployment. It pages out through our PBX operator, and in one simultaneous page, it goes out to all of these different people. It goes out to the coordinator, it goes out to our perfusionist, the operations supervisor, the charge nurses or leadership in the ICUs, our code nurse, RT, lab, radiology, pharmacy, and it also can page out for the mechanical CPR device if the ECMO code is being paged out in another location in the hospital that's not the emergency department. And now our eCPR resuscitation algorithm that we apply to every single patient looks like this. We have a witness arrest, right? So we know that criteria has been met. CPR is within 10 minutes on a shockable rhythm. So that's, tick, 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 3 things that we need to have present. If the patient does not meet those criteria, then we just do traditional conventional CPR. If they do meet inclusion guidelines and they remain in a refractory arrest that is not shockable and it's not achieving ROSC that's meaningful, meaning that there's actually a meaningful map, we will have our physician page out the ECMO team. They will obtain femoral vein and artery access. The ECMO page will be called overhead. All of those people will come running, and it's a zoo. However, everybody has a role, so it's actually quite streamlined. Again, if at any time these patients achieve meaningful ROSC, we will attempt to just do traditional ACLS because we don't want to abuse our ability to use ECMO for resuscitation. Because ECMO is not a benign therapy to apply. So once the cannulas are placed, our patients are placed on ECMO. We still use perfusionists to initiate. And then we all stop and we take a deep breath now that the patient is on ECMO, and we take what we call a medically effective ECMO timeout. And what that means is, what new information have we learned? Has a family member now come and said that this patient, has all these other comorbidities, or that the patient was actually found down and was agonally breathing? Especially with these out-of-hospital patients, there's a lot more information that you learn once family members arrive. We know that there are a couple of prognostic factors that are really important to consider when using ECMO in resuscitation. We know the time of CPR prior to time of ECMO flow is critical. So if you look at the 2 graphs here, the left side is the conventional CPR arm, and the right side is the eCPR or extracorporeal CPR arm. If you look at that 40 to 60 minute window is really the sweet spot here for time of CPR prior to ECMO. You see a 20% survival essentially in that group of patients. But if you look at the conventional arm of the 40 to 60 minutes, there were no survivors at 3 months. But we still see very, very good statistics, even in 60 to 80 minutes, almost 20% survival. And this was out of South Korea. We also know that time until ECMO flow, again, it's very important. So the purple graph is the eCPR group. The blue is the conventional CPR group. again, that sweet spot is really that 40 to 60-minute window. In the conventional group, they only saw a 5% survival, but again, they're seeing 30% survival here to discharge in the eCPR group when they were in that 40 to 60-minute window. We do peripheral cannulation for every patient in this setting because of the ease of artery and vein access in an emergency. Again, our physicians, like I said, start at the head of the bed, intubate the patient if not already intubated, and go directly to the groin. And in the setting of ongoing chest compressions with the mechanical CPR device, we obtain artery and vein access using ultrasound. Those are really the only pauses that we take during CPR if necessary, if imaging is a problem somehow. We put the drainage cannula in the femoral vein. It terminates in the the IVC, if any of you are familiar with ECMO. And then the return cannula is in the femoral artery, terminating in the common iliac. And then we always place a reperfusion catheter for distal limb perfusion. We have seen patients who have had wonderful ECMO outcomes, a perfect brain, and then they have a dead limb. And ultimately, that's pretty catastrophic when you have to have an amputation or a fasciotomy because your distal limb wasn't perfused appropriately. So this is a real arrest from our hospital, just to show you in action really that algorithm and how we resuscitate these patients. So again, we're in Southern California, so we have a patient here who's 70 years old who presented to our emergency department after he was surfing, playing in the ocean, and he walked out and had a witnessed arrest. So we know that it was a witnessed arrest and CPR was started right away by the lifeguards. So he'd already met 2 of those criteria. Upon arrival, his EKG showed ST elevations concerning for STEMI. So we know that his collapse with arrival here was 20 minutes because you see here his downtime upon arrival is 20 minutes. So he's just met another criteria for us. Immediately upon arrival, the automated CPR device is applied to the patient as he's rolled into the resuscitation bay. The next thing that is done is quick imaging to rule out tamponade or pericardial effusion, and to look at cardiac function. Most of the time, we expect to see total ventricular standstill in these patients, especially because they're continuing to fibrillate. So once the quick imaging is done, groin access is obtained with ongoing CPR. The ECMO team is paged out. This patient has obviously remained in refractory VF. Cannulas were inserted by the emergency physician. And then once the patient's on pump, we review all of the new information that we've learned. So has somebody come from the family and told us new information? We review the presenting pH. So your pH and your lactate can actually tell you quite a bit about the resuscitation. So if a patient's arriving with a lactate of 22 and a pH of 6.5, we can assume that the resuscitation itself wasn't very effective and that there's going to be significant multi-organ failure with that patient. So again, that medically effective ECMO timeout is a really important thing for us. Once the patient's on ECMO, if we haven't determined that there's any new information that requires a hard stop, then we will try to defibrillate the patient if they remain in a shockable rhythm, and we take them directly to the cath lab for PCI. And one of the ongoing conversations that we're always having is the purpose. Why are we on ECMO, and what is our plan going forward? So is the patient having pulmonary or cardiovascular failure, or both? Is the illness that's causing the failure, does it appear to be reversible? So that's obviously critical, right? And if it is reversible within a reasonable amount of time, wonderful. But if it's not, is organ replacement by transplantation an option? And this purpose for ECMO should be a continuous assessment, and it's really where that medically effective ECMO timeout starts. So these are our ED, out-of-hospital cardiac arrest, eCPR outcomes. We see a lot of out-of-hospital cardiac arrest at our ED, and we have cherry-picked our patients since go live with this program. So we put 15 patients on ECMO since go live of our program, and 6 have gone home neurologically intact. And so that doesn't seem like a very big end, but when you consider the fact that this was 6 otherwise dead patients who 5 years ago we would have had to have pronounced them. Because again, 30, 40 minutes into a resus and you can't achieve ROSC, typically that's when you call a code. We have applied this resuscitation to our hospital for our in-hospital cardiac arrest as well. And our overall eCPR outcomes compared to ELSO, which is the Extracorporeal Life Support Organization who holds the world's largest database on ECMO patients. It's an international consortium of ECMO centers who do report out on their eCPR outcomes. So Scripps is the green line, ELSO is the blue. Overall survival to discharge for out-of-hospital and in-hospital cardiac arrest, that's refractory to conventional CPR is reported as a 29% survival by also. We've had 19 patients go home who had 100% mortality because we were 30 minutes in and we couldn't do anything about to achieve ROSC in these patients. We had 19 go home neurologically intact, and so that's really meaningful for us. So how to start an eCPR program? Well, first and foremost, you have to identify the stakeholders and really set the vision, and you have to take a hard look at what your hospital is capable of too. Also says that an eCPR program hospital should ultimately be doing at least 20 cases of ECMO per year to have a well-rounded program. So we know that that includes stakeholders from heart failure cardiology, interventional cardiology, intensive care, emergency medicine, nursing especially, perfusion, and then really administration has to believe in this. And then you have to create the process and have a team and stakeholders who are very invested in program guidelines and adhering to those guidelines when things feel difficult. There's so much education that's involved, and really role identification and choreography that suits your institution is critical. The components of a successful program, again, are tons of education and supporting your team through the learning curve. So what that learning curve is having these patients that we look back on and go, oh my gosh, what were we thinking? And any hospital who does ECMO knows what I'm talking about, where you think, well, that patient didn't meet criteria. Why did we do that? And I think the important thing to do is support each other through those challenges, because if you consider the fact that the patients who we do place on ECMO, if you follow your guidelines, if you follow your criteria, these are patients who were otherwise dead, who otherwise had a 100% mortality. So when people come to you and who don't know much about eCPR and they say, oh, well, you have a 75% mortality rate, your response is, well, but they were 100% dead before. So it's just an interesting way to think, and there's sort of a culture shift in thinking. Following up and being accountable to your team, because these patients are truly multidisciplinary. So if your institution has a culture where things are siloed, cardiology really likes to own their patients and not consult on the ICU or cardiac anesthesiology or however your institution works. Accepting the fact that these patients are really, truly multidisciplinary will help you be successful in the future. Constantly reviewing your process through M&M or case review. We hold bi-monthly case reviews at Scripps. When our program was brand new, we ran every single patient that we placed on ECMO through the review. Now we've really honed in on the cases where we think we have something quite relevant to learn. So, if there was a catastrophic event with a cannulation, we want to review that. We want to talk about our process, or even timing. We had a case review recently where we felt that the mechanical CPR device was off the chest for too long, and we had too frequent of pauses, and we needed to understand what was going on with our pit crew roles, what was going on in that process, why we had so many pauses. And being able to review your CPR data from your monitors is critical to that. Participating in data registry is huge. We participate in the also data registry, so we run every patient through this registry to see how we can improve outcomes. Consider your volume. So again, if you're a high volume center, that's fantastic. You'll probably already have a multidisciplinary team in place. But if you're a smaller volume center, these sort of processes are harder to put into place. And supporting that culture shift, like I said, and really being a cheerleader striving for improvement. So again, the way things used to be for us, our ED was siloed, our cath lab was siloed, our ICU was siloed. But when we became an eCPR program with ED resuscitation, with ED docs independently cannulating for ECMO, it really had to be a marriage between all of the units. And what's not included here is really rehab and the floor. When we went live, some of our floor nurses had no idea what ECMO was. They'd never heard of it. So when they were assessing these groins after the fact, once the patients had been admitted to tele, we had to do some education pieces on what to look for. In Southern California, 3 major hospital institutions have founded the Too Vital to Die Foundation. It's really working on a major resuscitation overhaul. So I mentioned earlier on about routing patients to resuscitation centers. Essentially, in Southern California, you get routed based on your the geographical location that you have an emergency or an arrest. It's different for stroke or STEMI. You go to a stroke or a STEMI center or a trauma center. However, resuscitation is different. You get routed based on your catchment area. So what these hospitals are doing is we're taking donor money that was been given to us by private donors, and we're donating it back to the EMS providers and saying, hey, let us give you some of our donor funding so that we can all work together as part of that marriage between the pre-hospital setting and the hospital setting Our priorities right now are putting mechanical CPR on all of the ambulances. We'd like to provide training for EMS and have that spill into nursing and some of our physicians who manage these patients. And then ultimately restructuring routing of these patients based on hospital capabilities, having those immediate cath lab and ECMO capabilities for select patients rather than geographical locations. So there's this culture of stay and play versus scoop and go. For patients who meet criteria, i.e. witnessed arrest, shockable rhythm, probable reversible cause, we want those patients after 2-3 defibrillations that are unsuccessful, we want those patients scooped up and taken to a resuscitation center. So I'm going to do some sample case scenarios, 2 of them actually, just to see what your general feelings are about applying ECMO to a resuscitation patient. So this is a real patient. He's a 26-year-old gentleman who was found at La Jolla Cove. La Jolla Cove is a beautiful area where you can snorkel. He's pulled from the ocean and CPR is started a few minutes later by lifeguards. His initial rhythm is VS. ACLS ensues. He's unresponsive to defibrillation, and he does convert to asystole while he's en route to our emergency department. He does arrive 30 minutes later. His initial lactate is 17, and our physician wants to put him on ECMO. Is he a good eCPR candidate? So it's split here, 60-40. So 40% of you say yes, and about 60% of you say no. So that's really interesting to me. So a lot of people would be very upset if you didn't put a 26-year-old patient on ECMO. And the reason for that is, he's only 26. This is a youthful person with a whole life ahead of them. And this is part of the problem with having ECMO in your emergency department or anywhere really is sometimes pulling back is what you have to do, but it's really difficult to do. So ultimately, our physician wanted to put him on ECMO, and our nurses flew in the room and were screaming, "Don't you dare!" This patient was floating in the ocean. He was unwitnessed. So we say no. That isn't to say that it wasn't very difficult to say no, but ultimately, with an initial lactate of 17, found floating, and because of his asystole, we felt that ECMO would be inappropriate at that point. So we said he was not a good candidate. So here's another patient that came to us recently. He's a 57-year-old who had recently had stents placed 3 months prior to this hospitalization. He walked into our emergency department with epigastric pain and an elevated troponin. He was sent for a CT of his abdomen by our brand new resident who sent him unmonitored for a CT scan. As he came out of the CT scanner, he was unresponsive. So they called a code blue, did CPR in the hallway as he was rolling back to the emergency department, and he remained in persistent VS. What do you think about him? Is he a good eCPR candidate? So it looks like the majority of you say yes. And absolutely, he is an excellent ECMO candidate. It is likely that his stents reoccluded. This is a great case for us to review with our fellows and residents because he was sent for a CT of his abdomen for epigastric pain despite having an elevated troponin and stents prior. So it was a big learning experience for everybody in our ED. But he was placed on ECMO, and here he is with a couple of our ICU nurses and our ICU manager. He owns a restaurant in Southern California, and he always invites all the nurses to come and visit, but he's doing fantastic. So this is the last patient I'm going to leave you with because it is so incredibly profound what happened. So she was a 31-year-old female. She was 40 weeks pregnant, and she had a scheduled cesarean section. Upon admission of her prophylactic antibiotics, she suffered severe anaphylaxis with airway closure, hypoxia, and subsequent cardiac arrest. She did receive appropriate ACLS and treatment for her anaphylaxis. Despite 4 episodes of ROSC, she continued to have VF with profound hypotension, requiring CPR. So the highest we could ever get her blood pressure was around a systolic of 30. So when I say ROSC, it was very, 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 very weak ROSC. She had an emergent crash cesarean section of the baby with ongoing chest compressions, and we deployed our ECMO team. And this was her 48 hours later with her baby and her husband. getting ready to leave the ICU. So in summary, progressive EMS departments have really moved the needle on survival rates for cardiac arrest. Progressive hospital programs with ECMO capabilities can improve survival even further, but truly high-quality CPR has to precede them. Refined choreography and defined roles are critical to an efficient resuscitation. And it is stressful to do resuscitations no matter what. And it's chaotic for everybody, but it really can be streamlined with bundles of care and pit crew roles. And the more you educate to those, the easier it's going to become.